Okay, well, can you hear me? I hope so. I can't imagine a less exciting way of your looking at this, except hearing a disembodied voice talking about slides, but it is very convenient. So anyway, this is entitled Improving Informed Consent to Clinical Research, and that wasn't supposed to go that way. Okay. So the basic topic I want to talk about today is a concept called therapeutic misconception. It's a broadly recognized as a major problem in informed consent with clinical trials, and every few years NIH puts out another request for studies of therapeutic misconception because it is a problem that ethicists who deal with clinical trials worry about a great deal. So I'm going to call therapeutic misconception TM, and I know I shouldn't be using acronyms, but everybody calls it that. TM, we have a sort of a definition here that TM occurs when a research subject fails to grasp the distinction between clinical research and ordinary treatment, and particularly when that subject attributes therapeutic intent to research procedures. And that does happen a lot. So, look, it's, the last thing I'm going to do here is come out and say, research isn't good. Research is definitely good, and clinical trials are really important. But I think we need to remember that the purpose of research is to gather valid data, and not to provide the best treatment for the people involved. Now, look, I'm very aware, God knows I helped write some of them, that ethical rules require researchers to protect patients. That's standard. And, generally, clinical researchers are clinicians, and they tend to be fairly dedicated to that. And at least in my experience, they're very dedicated to taking good care of their subjects. But look, the clinical research is not treatment, and I'll try to emphasize by comparing these two on, look at the slide. So in treatment, you make individualized treatment decisions. In a clinical trial, what treatment you get is randomly assigned. If in treatment, the caregiver selects treatment based on the best interests of the patient, at least they should. In clinical trials, the physician or the caregiver is generally blind to what treatment is being given. Other treatments, for example, if the treatment causes side effects, you'll generally give other medications for it, or if the treatment isn't working well, one might add another medication. In clinical trials, we restrict those treatments for good reasons, but that's a different issue. And the dosage is going to be adjusted to individually for maximum benefit, and usually in a clinical trial will limit the amount of adjustment you can do. So here's my little, cute little thing. Imagine you're visiting your doctor, and your doctor says, look, I have 2 medications I could give you for this. but I don't know which one is best, so someone else is going to decide which medication you're going to get, and they're going to decide it by flipping a coin. And what's more, I'm not going to know which medication you're getting. I have some other medications that might help, but I won't let you have them. You're going to get exactly this dose unless you have really severely side effects, whether it's going to help you or not. Now, fairly obviously, we'd have trouble with, going to a care provider who said something like that. But that is, in essence, what you're getting when you get into a clinical trial. Look, as I said, I'm not trying to suggest that there's something wrong with doing clinical trials. We don't do these things trivially. The random assignment, blinding the care provider, limiting dosages and other medications, all that's done because that's how we get reliable data. If we don't do that, we come up with data that's essentially worthless. Indeed, a number of years ago, I wrote a paper which suggested that one of the problems we might have with the validity of trials is that the clinicians who provide the care in the trial often quit before it's necessary, or before they really have to, because they're so concerned about their patients, in quotes. So what I am going to suggest is that if we take informed consent seriously, and I think we should, people have to understand these things. So, we've been doing research on this now for 30 years, off and on, but, 30 years of research on the subject. So here's from just a quote from one particular subject in one particular study. We have tended to do semi-structured interviews to get this data. So so the interviewer asked, do you know how treatment in this study differs from ordinary care? Did they say what the treatment would be if you weren't in the study? No, I leave that up to them. I don't want them. I want them to give me the best treatment for what I have. If they don't, then I'll drop out. Interviewer, as far as you know, if they did have different groups, would the doctors decide which is the best one for you? Subject, I would assume he would decide which one was the best one for me. So that's very typical. The assumption is that, the doctor is going to provide the best care for me. So we've done a bunch of studies, and this is the outcome from one of them. We coded the text of the interviews for 2 different features. In some studies we've had 3, but these 2 were the belief that the treatment would be individualized to the subject, and did they have an unreasonable assessment of benefit, that is, one that couldn't have happened because of the way the study's designed. And conservatively, and I mean that conservatively because people say things that sometimes aren't really clear what they mean, and we tried to do the coding conservative. We found about 62% of the research subjects were either had the belief that the treatment would be individualized, or that they had this unreasonable idea. So we also did a look at, in another study, at people's assessments of the risks. And there's the standard interview question: what, if any, are the risks or disadvantages? So we coded the text of the statements, and so we found that almost 24% of the people reported there were no disadvantages or risks involved in being in the study. Like another, a little under 3% gave us things like, well, I have to drive a long way to get to this. I could get treatment at, from my local doctor, and I wouldn't have to drive so far. Another 14% said, basically, gave the risks that were associated with the control condition with the standard care. And about 46% reported side effects of the experimental intervention. So of the total number of subjects, 86% of them had no apparent awareness of risks associated with the design of the trial, which is, after all, what therapeutic misconception is about. So here's the 13.5%. And even here, so a bunch of people talked about placebos, because in these trials we designed involved looking at placebo trials. And so that people did get was something of a risk. There's a small number of people who expressed concern about the double-blind, and otherwise everything was, well, there are always risks. So basically, therapeutic misconception is really pervasive. So most people, what we find out repeatedly is that people join clinical trials because they believe it will benefit them. If you listen to the advertisements on TV, I don't know where you are, you have these, but in Greater Boston, there are always things about, oh, you can come to such and such a hospital, and we've got lots of clinical trials you can join, as though this is, or lots of research you can join, as though that's going to be essentially beneficial to you. But maybe half of the people think that there's something going on there. We have a lovely example, which I didn't put up here, of somebody who we asked about the thing, and she said, well, there are two arms to this. I mean, they can give it to me either in my right arm or my left arm. And of course, that's her understanding of there's somebody saying to him that this is there are two arms to the trial. There's the experimental arm and the control arm, but she took it literally anyway. So we have developed a scale. There's a site there. It's a 10-item scale. It's pretty small. It's pretty quickly taken, and it's reasonably valid. I mean, we used the coded semi-structured interviews as the validating thing. And of course, coded semi-structured interviews aren't perfect gold standards either, but we got good reliability with this. So we had 220 participants at 4 medical centers, and we coded all this stuff, 28 items, and we ended up in this case here, I said before we had two criteria, the benefits, unreasonable assessment of benefits, and that the treatment is individualized. We added the purpose to this because it does seem that people need to understand that what is going on here is research, not essentially treatment. So anyway, we have this 10-item scale. There are these three factors. They're very strongly correlated. Some people who've done this, who have used the scale again, found that you couldn't separate out the three factors, that they were so tightly correlated. We did find three factors, but they are tightly correlated. And so those of you who are into scale construction, there's on the thing on the screen is the ways in which you assess how good a scale this was, about a 0.65 positive predictive value and a 0.68 negative predictive value. That's, and there are copies of that available. So, that's very nice. You get a scale and everybody likes a scale and so forth, but we thought it would be really nice if we could do something about this, okay? Because otherwise you're just doing an academic exercise of no particular value. So a couple of us talked about this for a while. And we have this theory of therapeutic misconception. Other people have other theories. We're not unique. I happen to think this is right, but of course that's because I constructed it. So, people understand what's going on in the context of cognitive frames. They use those frames to interpret what's going on around them. And what I'm basically going to say is that researchers and subjects have different frames, okay? So the researcher's primary frame is, look, you design a clinical trial in a scientific cognitive frame, and it's an abstract concept about how you demonstrate the efficacy of a treatment. And if you've done any clinical trials or you've read them even, you understand that this is a standard that science has established as the gold standard for the efficacy of any evidence of the efficacy of a treatment. It's an abstract frame. It talks about cases as units, okay? And they get managed according to a protocol, and all of the activities of the researcher are guided by that. We need a predetermined number of these units that's done by a power analysis. So we want to have, the same sorts of people in each group, and the standard way of doing that. Some other places do it. Sometimes we do it differently for practical purposes, but usually we randomize people to each group because we have statistical models that allow us to assess how likely various differences are going to be when they're really assigned at random. And of course, we don't want either the physician or the participant having any expectation of to which is what group the subject is in, because that might affect both of their judgment and behavior. So doses are restricted to predetermined ranges so that the intervention is clearly defined. That allows us to write papers saying, okay, this is what was the intervention. We want to keep the other medications out because they might be effective. I mean, that's not, of course, the way a patient would see this, but that's the way. But it may also interfere with. So, at any rate, we don't want to contaminate the result with other medications. And as I have highlighted in big red letters, this is independent of the specific patient's needs. Now, the participants have a different frame. They come at this from their personal needs. They don't view the thing from the top down, the designing everything. They do it from the point of view of the individual units, that is themselves, and their medical needs. They come for help with a problem and tend to see the study in that context. So, when you start telling them about design features, they're very creative in making up reasons for the design features that are consistent with their idea that this is there to help them. So I have this example, when you think about who's eligible for the trial, if you're a researcher, there are criteria about it. There are certain diagnostic criteria. There might be certain age. We might only take women. We might take, 15 to 30-year-olds or whatever. We may have, only people with the 6 criteria on their blood tests, or depending on the trial, right? But that means that's an effort to clearly define the group that is involved, so that you're doing away with any, so that you're clear about what you've tested, essentially. Participants, when they talk about eligibility, tend to think that what is being talked about is whether this would be beneficial to them. That's when we interview them, they tend to say that the doctor found they were eligible, and to them that means that they're likely to benefit. Now, if that was all, if that was the whole picture, people would quickly discover that they're talking in different languages. Okay, so we came to realize that there are kind of some secondary frames. And so for this researcher secondary frame, and I think I have written here that it's particularly true among those who are actively delivering treatment to their patients. And I think you should never, when you think about clinical trials, we often think just about the person who sits there and designs them. But these are generally delivered by clinicians, right? And so they have, there are, of course, the ethical standards that say, you have to protect your patients from mistreatment in this, and we have institutional review boards, or in other countries we call them research ethics committees, that try to make sure that this study is not going to put any patients at risk. And besides that, we tend to believe that the people who are doing research are doing the cutting edge work, they're particularly well trained, and so forth and so forth. It is certainly true that in most cases, the subject will get more time and attention and better monitoring than they would if they were not in a clinical trial, if they just got routine treatment. So the researcher is comfortable saying, that they're going to help that this is in the best interests of their subject. Now, participants have kind of another secondary frame, and it's something like, well, it's hard to figure out what all this research stuff is about. It's pretty technical. Research is really important. It's a really good thing to do, and they're studying me. So a lot of times when we interview subjects in trials, they seem to view the research as a series of single case studies rather than as a randomized trial. They're studying me. They're looking at whether this is effective on me. So the researcher's secondary frame allows them to be comfortable telling the participant that they're going to be very well cared for and that this is really, gonna help them. And that, added to the participant's own misunderstanding of what's going on, allows these to have this therapeutic misconception. Now, as I said earlier, we've been trying to see if we couldn't do something about this. And if that theory that I laid out of the, cognitive frames of the two participants is right, what we need to do in order to get subjects to understand is not just tell them what's going to happen to them, but why. They need to see their participation in the context of a research design, not just as a series of items that we give them. So we've come to feel that they need a mini course on how research is designed. So we ran a test of this. We did this on mock clinical trials. We may get around to doing this on real clinical trials, but we did it with 4 different conditions: cancer, cardiac stents, depression, and diabetes. And we took individuals who really would be eligible for the mock trials we had. And we randomized them either to a mock ordinary consent, which we worked up with based on real consents that had been used, or real consent forms that had been used, or what we called an enhanced consent. And these were all delivered by I'm sorry, I shouldn't have done that. And these are all delivered on a computer so that the researcher who was recruiting the subject didn't actually know which arm of the study they went into. So we did, like any other clinical trial, try to get rid of external variants. So we used an experimental disclosure that's available on YouTube. If you want to look at it, the URL is there. If you want to use this in your own clinical trials for consents, feel free. I'd love to know what results you get, but anyway, that's another issue. So the reframing basically goes through and it provides a short course in the design of clinical trials. It does reduce therapeutic misconception. The control on our scale, the control group had a score of about 31, and the The experimental group had a score of about 25. That's very significant difference. It's, in a sample of 144, that's a pretty decent outcome. Now, of course, the reason we did this on a mock trial is because we couldn't persuade anybody who was running a real trial to use it because they were concerned that it would affect recruitment. So we asked people at the end of this, would you be willing to join this trial? And as you can see, in this 154 subjects, 154 subjects, I'm sorry, we did not get a significant difference. Now, we do have a trend, and I would suspect that, if you did this in a very large trial, you might have an effect on recruitment. There is that trend. Now, one of my colleagues who I've worked with for many years, Paul Applebaum, says, well, of course, if we're going to get them to understand what the differences are, then, some people are going to back out. And so I do think it's true. This might require us rethinking some designs. It might require us to try to recruit slightly more people. I do think it would defend research from the various ethical and other critics who simply don't like this type of research. So that's it. If people have questions, I'd be glad to answer them. And I believe this is up to Dee to ask any questions anybody might have.
Hi, Dr. Lidz. Thank you so much for your presentation. Feel free to type in your questions as you think of them, and we will ask Dr. Lidz them for you. You can use the questions box in GoToWebinar. I just want to give a little shout out that we have several webinars coming up this spring. One later this month, April 18th, on which is for the transitions ACR, and features Dasha Mulvery and Carol Schubert. That's on behavioral health disorders and employment for justice-involved adolescents. And then we have a webinar May 31st, which is another transitions ACR webinar talking about preventing disability among young adults with mental health conditions, which will feature Michelle Mullen. And there'll be another one done by Ekaterina Pervova, also in May. I just don't have the title of right now. But if you want to know about those webinars, please sign up for our newsletters or visit our website. So, not sure if you answered some of these questions, but let's see. Someone wants to know, how do I know when I'm not understood?
That's a good question. I think encouraging the subject to talk about things on what I did say that one of our problems, of course, was when we would try to code responses to semi-structured interviews. Sometimes we weren't totally sure, but listening seems to be the best technique. If you you can always ask so tell me what you make of what I told you about that. What do you think about participating in this. And if you give them a few minutes to talk, I think you'll find that people kind of tell you by their answers when they're not understanding. Although it's not always true. One of the time that we saw this most clearly was Dr. Applebaum and I were doing a interview study on real clinical trials, and we were finding that at the end, Paul would ask them 12 questions, and we got accustomed to people just, they wouldn't get it right. We'd hear, the 12 questions, but we finally got one woman who was really bright, and she got through the first 11 questions, and she got everything right. And I was watching this, and I was so excited because we finally had somebody. The last question was, so how would this affect your treatment? And the woman sort of looks up, and she mumbles something about, he did say random, and then she sort of shakes her head and says, doctor's name will do what's best for me. And even though she understood randomization and placebos and all that sort of stuff, once one let her just answer how it impacted her, even she had that sort of trouble. And then we began realizing this was a big problem. I hope that answers.
Okay. So someone asked about consents for doing patient case reports and case series record reviews. Is, I guess, that different than what you would do?
Yes, I think, record reviews are certainly quite different since, you're not involved in an active intervention. And there you're basically dealing with issues of privacy and whether, and again, they just need to understand that you're doing this for a research purpose. You're trying to learn. You're not doing this for their clinical care. And then you can talk about, why you want to do this research. And I think most people will, be rather enthusiastic about contributing their information to solving a problem, as long as they feel confident it's not going to be their information isn't going to be broadcast all over the place. But people tend to be very excited about science. This is totally irrelevant, but I remember being about 8 years old, and for some reason or another, my father took me to donate some blood to some sort of trial they were studying, or some sort of study they were doing about young people. And at the end of it, they gave me a prize of being able to go into a laboratory where they had a bunch of used lab equipment and told me to take a few things. And I thought this was so amazing because I thought I had contributed to science, and here they were doing this for me too. It was amazing. I loved it. But I was, of course, 8 or 10 or whatever it was. Anyway, so what else?
So I had a question. The study you've recently completed about therapeutic misconception, how do IRBs feel about this new way of consenting patients?
Well, we have not had a chance to try this in a real trial. When I present this to people who do, they are generally quite enthusiastic. I've been pleased and surprised that that people. I mean, after all, most of us take informed consent seriously and think it's important. And if you can do this without ruining the research, generally people are pretty enthusiastic about it.
Awesome. Do you plan on doing any additional research in this field? I know.
Well,
anyone?
I am allegedly retired, but I will certainly help if one of my colleagues decides they want to undertake this. There are several people who have tried this out in various contexts, but so far we haven't had the sort of systematic trial on a large group of people that would allow us to report this. I mean, we have had people try it on, 20 subjects, but not, not randomizing people to getting it or not getting it. And but so far, those experiences have been fairly positive, I think.
We have a comment. She's saying, I sit on the UMass Medical School IRB, and I think many people would be very enthusiastic about this. We often struggle with the long consent forms and worry that subjects won't understand all of the procedures being asked of them. The new common rule will help some of this, but it would be good to have this type of presentation at an IRB meeting.
Well, I'd certainly be willing to talk to the UMass IRB. I feel, people don't understand the consent forms, and often they don't even bother to read them. So I've always emphasized talking to subjects about, when I train my staff to get consent, I tell them, look, you give them the consent form and tell them they're free to read them, but here's what you need to make sure they understand. And it's, generally it's 3 or 4 items. It's not, now of course we're doing psychosocial research. We're not doing, typically we're not doing fancy biological studies, but I really think that, it's very hard for people to follow more than about 4 key items at once. It's a problem. So I think it's important to have this sort of a dialogue, and hopefully that allows people to understand what's going on.
Okay, we have another question. It says, proxy decision maker in psych trials discussed in the CATIE or CATIE study. Do you know if this got published?
I can't, I'm sorry, I can't hear you, Dee. Can you repeat that?
Sure. Proxy decision maker in psych trials. I guess this was discussed in the CATIE study, and it's KATIE.
Yeah.
Did this get published?
Yes, this has been published. Let's see, where did we publish the last one? I'd have to look but if somebody wants to give me an email, I'll give you the reference to it. We published the trial and the scale in one thing and the outcomes of the trial in another. I think it might be in academic medicine, but I need to go back and look at that.
Okay, I will send Anne your email address so she can get in touch with you.
Okay.
Or I can give you Anne's email address depending on how that works out, so you can connect with her about that.
Either way.
Okay. Judy, who also sits on, who sat on the, had the comment earlier that she sits on the IRB board. She says she agrees that doing social science work is different than a phase 3 clinical trial, but the PIs and research coordinators are required to read through the consent form with the subject rather than just hand it to them.
Yes, I know that that's what the rule is. I, you know, and I'm sorry, but I really want them to understand what's going on, and you can say that I've not been good, but I really take very seriously having people understand what's going on. And if you read them the material on the consent form, their eyes glaze over. It's really quick, and if you don't believe me, you should try doing this a bit. The people just like, oh my God, it's a ritual. You're making me listen to this. Whereas if you sit and talk with them, here are the key points of what's going on, and you should feel free to read it. Now, there are exceptions to that, of course. If a person can't read or has trouble reading, then you got to read it to them. I agree with that. But I'm not a big proponent of reading the stuff at somebody.
Well, thank you, Dr. Lidz. No other questions have come in. If
Okay.
we don't get in a sec, is there anything you would like to say in closing?
No, except to thank people for listening, and you can reach me at any point at chuck.lids@umassmed.edu, and I'm more than willing to continue to dialogue about it. Thanks a lot.
Thank you so much for taking the time to give your presentation this afternoon, and this will be posted on SPARC's website probably sometime next week, so people can refer to it and find the slides or watch the presentation again. Thank you, everyone.
Bye-bye.